Hi class, I'm Dr. Five. Welcome. I'm going to cover today the endocrine system. Please keep in mind I've only covered certain portions of the chapters for this. Students are responsible for reviewing the entire chapters pertaining to the endocrine system. All right, so let's get started with some mechanisms of hormonal regulation. The endocrine system responds to specific signals by synthesizing and releasing hormones into the circulation. General characteristics, specific rates and rhythms of secretion. Hormones operate with feedback systems, and hormones affect only cells with appropriate receptors. Steroid hormones are either excreted directly by the kidneys or metabolized by the liver. Hormones are classified according to the structure, gland of origin, effects, and chemical composition. As you can see here, there's hormones from different areas, and these are listed here. Regulation of hormone release. Hormone release is regulated by chemical factors such as glucose level, endocrine factors such as hormone from one gland controlling another, or neural control, which is stress-induced release of catecholamines from the adrenal medulla. There's negative feedback, which is the changing chemical, neural, or endocrine response to the stimulus negates the initiating change that triggered the release of the hormones. And there's a figure in the textbook that you can look at that gives you more information on the negative feedback loop. Hormone transport. There's peptide or protein hormones, pituitary, hypothalamic, and parathyroid hormones, and insulin. These are water soluble and circulate in free, unbound forms. Water-soluble hormones have a short half-life, and lipid-soluble hormones such as cortisol, adrenal androgens, these are transported bound to a carrier or transport protein. Only free or unbound hormones can signal a target cell. Hormone receptors. Only cells with appropriate hormone receptors for that hormone are affected. Target cell hormone receptors have two functions: to recognize and bind with high affinity to their particular hormone, and to initiate signal to appropriate intracellular. The more receptors, the more sensitive the cell. There's upregulation, which low concentrations of hormone increase the number of receptors per cell. Or there can be downregulation when there's high concentrations of hormones that decrease the number of receptors. Okay, plasma membrane and signal transduction. First messenger, the hormone secreted into the bloodstream, and it carries a message to the target cell. There's signal transduction, in which the process by which this message is communicated into the cell. Second messenger, there's cyclic adenosine monophosphatase, or CAMP. Second messenger molecules initiate the link between the first signal, or the hormone, and inside the cell. Cyclic guaiacosine monophosphatase, or cGMP, activates a number of physiologic processes. And calcium is an important second messenger. The formation of calcium calmodulin complex, which mediates the effects of calcium on intracellular activities. Here's just some more information on the first and second messenger system. Steroid lipid-soluble hormone receptors, these are synthesized from cholesterol, androgens, estrogens, progestins, glucocorticoids, mineralocorticoids, vitamin D, and retinoid are those lipid-soluble hormones. Thyroid hormones are lipid-soluble, but are not synthesized from cholesterol. The hypothalamic pituitary axis, or HPA, this forms the structural and functional basis for central integration of the neurologic and endocrine systems of the neuroendocrine system. The hypothalamus, this is located at the base of the brain, and the pituitary gland, which is located in the sella turcica. The anterior pituitary has three regions: the pars distalis, pars tuberalis, and pars intermedia. The posterior pituitary has three parts: the median eminence, located at the base of the hypothalamus, the pituitary stalk, an infundibular process, also known as pars nervosa or neural lobe. Communication or anatomic connection between the hypothalamus and pituitary is quite elaborate. The hypothalamus is connected to the anterior pituitary by way of portal blood vessels. And there's a figure in the textbook on pituitary hormones and their target organs that you can look over. Okay, hormones of the posterior pituitary. Secretes two polypeptide hormones in the posterior pituitary. We have the antidiuretic hormone, or ADH. This controls plasma osmolality, acts as vasopressin 2 receptors of renal tubular cells to increase the permeability, and it leads to an increase of water reabsorption into the blood and production of more concentrated urine. The effects may be initiated by hypercalcemia, prostaglandin E, and hypokalemia. At high serum levels, the ADH acts as vasopressin 1 receptors, and it causes vasoconstriction. We have oxytocin, which is responsible for contraction of the uterus and milk ejection in lactating women. It may also affect the sperm motility in men. It plays a role in the brain's responsiveness to stressful stimuli. Hormones of the anterior pituitary, there's two main cell types, chromophobes, which are non-secretory, and chromophils, which are secretory. The major trophic hormones are ACTH, melanocyte stimulating hormone, luteinizing hormone, growth hormone, prolactin, follicle stimulating hormone, and TSH. And the functions of these hormones are summarized in the book, and there's also some here on this chart, the different functions from the anterior pituitary and posterior pituitary. The pineal gland, this is located within the brain itself and is composed of photoreceptive cells that secrete melatonin. Now with melatonin, this is released, is stimulated by exposure to dark, and it's inhibited by light exposure. It regulates circadian rhythm and reproductive systems, including secretion of GnRH and the onset of puberty. It has a role in immune regulation, increased nitric oxide release to remove toxic oxygen-free radicals, and decreasing insulin secretion. Okay, moving on to the thyroid gland. This is composed of two lobes that lie on either side of the trachea, inferior to the thyroid cartilage. It can be palpated on swallowing. Regulation of thyroid hormone secretion. This is that negative feedback loop. Thyroid stimulating hormone, or TSH, is secreted by the anterior pituitary. And the effects of TSH, immediate increase in the release of stored thyroid hormones. There's an increase in iodine uptake and oxidation. Sorry, there were some sirens going by, so I had to pause that. There's an increase in thyroid hormone synthesis, and there's an increase in synthesis and secretion of prostaglandins by the thyroid. Synthesis of the thyroid hormone, there's a summary in the textbook that you can review on that. Parathyroid glands, there's two pairs normally present, but may range from 2 to 6. These are located behind the upper and lower pole of the thyroid gland, and these produce parathyroid hormone, or PTH. And this works with vitamin D to increase the serum calcium concentration. The overall effect of parathyroid hormone secretion is to increase calcium and decrease the phosphate level. Now, the pancreas, we have the endocrine functions of the pancreas. The endocrine gland produces hormones, and the exocrine produces digestive enzymes. We have the islet of Langerhans. There's 4 types of hormone secreting cells here. We have alpha cells, which secrete glucagon, beta cells, which secrete insulin and amylin, delta, which secrete gastrin and somatostatin, F or PP cells, which secrete pancreatic polypeptide that stimulates gastric secretion and antagonizes cholecystokinin. These hormones regulate carbohydrates, fat, and protein metabolism. And this chart is just the different functions and the cells involved there. Insulin, this is secretion regulated by chemical, hormonal, or neural control. Secretion diminishes in response to low blood glucose levels, high levels of insulin, and sympathetic stimulation of alpha cells. This facilitates the rate of glucose uptake. Anabolic hormone that promotes synthesis of proteins, carbohydrates, lipids, and nucleic acids. Functions mainly in the liver, muscle, and the adipose tissue. We have glucagon, which is produced by the alpha cells in the GI tract. High glucose causes inhibition of glucagon, and low glucose levels promote glucagon release. Incretins, which are secreted in the presence of carbohydrates, proteins, and fats, and these control those postprandial glucose levels. Amylin is a polypeptide hormone secreted in response to nutrient stimuli. This regulates glucose by delaying nutrient uptake and suppressing glucagon after meals. Somatostatin, this is hormone essential for carbohydrate, fat, and protein metabolism. And we have ghrelin, which increases before meal and stimulates appetite, and it falls soon after a meal to promote the feeling of satiety with eating. The adrenal cortex, there's 3 zones: the zona glomerulosa, which produces mineralocorticoid aldosterone; zona fasciculata, which secretes glucocorticoid cortisol, cortisone, and corticosterone; and the zona reticularis, which secretes mineralocorticoids, aldosterone, adrenal androgens, and estrogens and glucocorticoids. Glucocorticoids have metabolic, neurologic, anti-inflammatory, and growth-suppressing effects. The most potent is cortisol, which is necessary for maintenance of life and protection from stress. Mineralocorticoids directly affect ion transport by epithelial cells, causing sodium retention and potassium and hydrogen loss. Aldosterone is most potent and acts to conserve sodium by increasing the activity of the sodium pump in the nephrons in the kidney. Now, the adrenal medulla, this functions as a sympathetic ganglion without postganglionic process. There's chromaffin cells, pheochromocytes, which store and secrete catecholamines epinephrine and norepinephrine. These are released by physiological stress to the body, and this has to do with the fight or flight response. Okay, let's look at some alterations of hormonal regulation. The syndrome of inappropriate antidiuretic hormone, abbreviated SIADH. This is when there's high levels of ADH or antidiuretic hormone. This can complicate malignancies, pulmonary disorders, CNS disorders, surgical procedures, and certain medications. Pathophysiology, there's enhanced renal water retention, which leads to dilutional hyponatremia and hypoosmolarity, and the urine that is inappropriately concentrated with respect to serum osmolarity. Clinical manifestations, these result from hypotonic hyponatremia and is associated with hypervolemia and weight gain. Sodium level rapidly decreases from 140 to 130. The patient may have thirst, impaired taste, anorexia, dyspnea on exertion, fatigue, adult sensorium, and peripheral edema is usually absent. And when the sodium level is from 130 to 120, there's severe GI symptoms, including vomiting and cramps. When the sodium level is less than 115, the patient may have confusion, lethargy, muscle twitching, and seizures. And with a sodium level from 110 to 115, there can be irreversible neurological damage. Evaluation is done with serum hypoosmolality, less than 280, and hyponatremia, less than 135. Urine hyperosmolarity, urine sodium excretion that matches sodium intake, normal renal, adrenal, and thyroid function, and the absence of conditions that can alter volume status. Treatment is to treat the underlying cause. Here's different causes that can lead to syndrome of inappropriate diuretic hormone. Diabetes insipidus. This is an insufficiency of the antidiuretic hormone leading to polyuria and polydipsia. There's three forms. There's neurogenic or hypothalamic, nephrogenic or renal, and polydipsic or polydipsia polyuria syndrome. Neurogenic is the form encountered most often, and it's caused by insufficient amounts of the antidiuretic hormone. There can be an organic lesion of the hypothalamus, pituitary stalk, or posterior pituitary that interferes with ADH synthesis, transport, or release. Nephrogenic, which there's insensitivity of the renal collecting tubules to ADH, and this can be genetic or acquired. Dipsogenic occurs when excessive fluid intake lowers the plasma osmolarity to the point it falls below the threshold of ADH secretion. And this may be associated with some psychiatric disorders. Pathophysiology, all are characterized by the ability of the kidneys to decrease permeability to water, causes excretion of large volumes of dilute urine, and increase in plasma osmolality. Clinical manifestations: polyuria, nocturia, continuous thirst, and polydipsia. Evaluation: a water deprivation with measurement of serum osmolarity and plasma ADH levels, which can be hazardous in severe cases. And treatment is based on the extent of ADH deficiency and or treating the underlying disorder that's causing this. And here's different classification of these types of diabetes insipidus. All right, disorders of the anterior pituitary. We have hypopituitarism. There's an absence of selected pituitary hormones or the complete failure of all pituitary hormone functions. This results from inadequate supply of hypothalamic releasing hormones, damage to the pituitary stalk, or inability of the gland to produce hormones. The most common causes lie within the pituitary gland itself. Other causes: there can be a space-occupying lesion that can compress the gland. Head trauma can lead to this. Destruction of the gland, infections such as meningitis, syphilis, or tuberculosis, and certain drugs can lead to this as well. Pathophysiology: the pituitary gland is highly vascularized and extremely vulnerable to ischemia and infarction. Clinical manifestations: there's panhypopituitarism. All hormones are deficient, cortisol deficiency, thyroid deficiency, and there's loss of secondary sex characteristics from lack of FSH and LH. ACTH deficiency can lead to nausea, vomiting, anorexia, fatigue, and weakness. With a TSH deficiency, there can be cold intolerance, dry skin, mild myxedema, lethargy, and decreased metabolic rate. FSH-LH deficiencies: amenorrhea with atrophic changes in the vagina, uterus, and breasts, and can also have atrophy of the testes in men. GH deficiency in children: this can be genetic or caused from tumors. In adults, there can be increased body fat, decreased muscle problems, depression, social withdrawal, fatigue, loss of motivation, and diminished feelings of well-being, and osteoporosis. Evaluation is measurement of the hormones, and an MRI or CT scan may also be indicated. Treatment is targeted at replacing the target gland hormones that are deficient, glucocorticoids, and steroid replacement therapy. Okay, now hyperpituitarism, primary adenoma. This usually begins slow-growing tumors. It's usually a benign slow-growing tumor that arise from cells in the anterior pituitary, most commonly those that secrete GH and prolactin. There's gene mutations, including those associated with multiple endocrine neoplasia syndromes. Pathophysiology: there's local expansion of pituitary adenomas, which may cause neurologic and secretory defects. The tumor may impinge the optic chiasm and cause visual disturbances. Clinical manifestations related to the tumor growth and hormone hypersecretion or hyposecretion. There can be visual changes, temporary blindness, decreased libido, receding secondary sex characteristics, hypothyroidism, and hypocortisolism symptoms. Evaluation is with hormone assays and may also need an MRI or a CT scan. Treatment, the goal is to protect the individual from the effects of tumor growth, to control hormone hypersecretion, and to replace any deficient hormones. Hypersecretion of the growth hormone acromegaly. This is when there's excessive levels of growth hormone and concomitant elevation of IGF-1. Gigantism, this is the effect of increased growth hormones on the long bone growth in children and adolescents. The primary, most common cause is a primary autonomous GH secreting pituitary adenoma. This occurs more in women than men and is usually diagnosed in the 40s or 50s. It's a slowly progressive disease, and if untreated, it can be associated with a decreased life expectancy. There's an increased number of deaths associated with acromegaly because caused by cardiac hypertrophy, hypertension, atherosclerosis, type 2 diabetes, or coronary artery disease. Malignancies such as breast, colon, and lung cancers are also associated with this. Pathophysiologically, children and adolescents whose epiphyseal plates have not closed, there's excessive skeletal growth. Growth hormone has significant effects on glucose, lipid, and protein metabolism. Clinical manifestations include an enlarged tongue, interstitial edema, an increase in the size and function of sebaceous and sweat glands, coarse skin and body hair, large joint arthropathy with swelling and decreased range of motion, kyphosis. There can be enlargement of facial bones. Patient may have backache, arthralgia, arthritis, and may have symptoms of diabetes such as polyuria and polydipsia. Evaluation, elevate the IGF-1 levels and GH suppression during oral glucose tolerance testing. Treatment is to normalize the growth hormone and IGF-1 serum levels, restore normal pituitary function, and prevent complications from tumor expansion. Transphenoidal surgery or endonasal endoscopic surgery for removal of adenoma, or the patient may have radiation therapy or treatment with octreotide. Hypersecretion of prolactin or prolactinoma. Prolactinomas are pituitary tumors that secrete prolactin. We can have microprolactinomas, which are usually encapsulated and non-invasive, or macroprolactinomas, which expand to the optic chiasm and invade local structures. Physiologic actions of prolactin include breast development during pregnancy, postpartum milk production, and suppression of ovarian function in nursing women. Medical conditions or medications can elevate prolactin levels. There can be renal failure, hepatic cirrhosis, polycystic ovarian disease, breast stimulation, and chest wall lesions. And this may be elevated in those with primary hypothyroidism. Medications that block the effects of dopamine, such as risperidone, chlorpromazine, metoclopramide, tricyclic antidepressants, methyldopa, and estrogens are also associated here. Pathophysiological information, there's sustained increases in serum prolactin concentrations, and CNS symptoms may develop. Clinical manifestations include galactorrhea, menstrual disturbances, amenorrhea, hirsutism, osteoporosis, hypogonadism, and erectile dysfunction in men. Evaluation, the prolactin level is more than 200. May also need to have an MRI done as well. Treatment, dopaminergic agonists are the treatment of choice for this disorder. Alterations in thyroid function. Disorders of thyroid function may develop from primary dysfunction or disease of thyroid glands, or secondarily from pituitary or hypothalamic alterations. Primary thyroid disorders result in alterations of thyroid hormones. TH levels with secondary feedback effects on the pituitary TSH levels. Central or secondary thyroid disorders are related to disorders of the pituitary gland TSH production. So we have hyperthyroidism, also called thyrotoxicosis. This is a condition that results from any cause of increased amounts of thyroid hormone. Hyperthyroidism is a form of thyrotoxicosis in which excess amounts of thyroid hormone are secreted from the thyroid gland. Primary hyperthyroidism is Graves' disease, toxic multinodular goiter, or solitary toxic adenoma. Central or secondary hyperthyroidism, this is less common and it's caused by a TSH secreting pituitary adenomas. This disorder is more prevalent in iodine deficient populations. Clinical manifestations include increased metabolic rate with heat intolerance and increased tissue sensitivity to stimulation by the sympathetic division of the ANS. Evaluation, looking at the T4 and T3 levels and looking for a decreased TSH level. Treatment depends on the cause. Antithyroid drug therapy or radioactive iodine or surgery can be used to treat this disorder. Now, Graves' disease, underlying cause of 50 to 80% of cases of hyperthyroidism. The exact cause is unknown, but genetic factors interacting with environmental triggers play a role in the autoimmune thyroid disease. This results from a form of type 2 hypersensitivity. Clinical manifestations, ophthalmology and pretibial myxedema, exophthalmos, diplopia, photophobia, and blurred vision. Treatment is with antithyroid drugs, radioactive iodine, or surgery. On the opposite side of that, we have hypothyroidism. This is a deficient production of the thyroid hormone by the thyroid gland, and this is the most common disorder of thyroid function. Primary is the most prevalent. Central or secondary, this is less common, and it includes conditions that cause either pituitary or hypothalamic failure with failure to stimulate normal thyroid function. So clinical hypothyroidism, there's mild thyroid failure, elevated TSH levels with normal levels of circulating TH. Pathophysiology, there's autoimmune thyroiditis or Hashimoto disease, iatrogenic loss of thyroid tissue after surgical or radioactive treatment for hyperthyroidism, head and neck radiation therapy, medications, or endemic in iodine deficient diets. Clinical manifestations, generally this affects all body systems. There's decreased energy metabolism and decreased heat production. Patient may have cold intolerance, lethargy, tiredness, diastolic hypertension, and a decrease in the thyroid hormone leads to an increase in TSH production and may cause a goiter. Myxedema coma, this is a medical emergency. There's a diminished level of consciousness associated with severe hypothyroidism. There's precipitating factors that can bring this on, including infections, discontinuation of thyroid supplements, overuse of narcotics or sedatives, or the consequences of an acute illness. Evaluation, look at the clinical symptoms and look for increased levels of TSH and decreased total T3 and both total and free T4. Treatment is generally levothyroxine. And here it has the different clinical manifestations or symptoms, signs and symptoms that you'll see with patients with hypothyroidism. Okay, alterations in parathyroid function or hyperparathyroidism. This is characterized by greater than normal secretion of parathyroid hormone and hypercalcemia. This is classified as primary, secondary, or tertiary. Pathophysiology, primary, this is usually a sporadic disease characterized by inappropriate excess secretion of PTH by one or more of the parathyroid glands. Secondary, caused by an increase in PTA secondary to chronic disease states such as chronic kidney disease. And tertiary, excessive secretion of PTH and hypercalcemia that occurs with long-standing hyperparathyroidism. And this here chart just shows the different causes here as primary, secondary, and tertiary. Clinical manifestations, most patients are asymptomatic. There may be hypercalcemia and hypophosphatemia. Symptoms related to muscular, nervous, and GI systems. And this includes fatigue, headaches, depression, anorexia, and nausea and vomiting. Evaluation, look for increased ionized calcium concentrations in face of elevated intact PTH level. Treatment, there's surgical removal of a solitary adenoma, biphosphonates, glucocorticoids, and calcimimetics can use to treat this disorder. Alterations in parathyroid function, hypoparathyroidism. This is an abnormally low level of PTH, most commonly caused by damage to the parathyroid glands during thyroid surgery. There are genetic syndromes associated with this, such as familial hypoparathyroidism and DeGeorge syndrome. Hypomagnesemia may cause decrease in PTH secretion and function. Pathophysiology, there's a lack of circulating PTH, causes depressed serum calcium levels and increased serum phosphate levels. Resorption of calcium from bone and regulation of calcium resorption from the renal tubules are impaired. Clinical manifestations are related to hypocalcemia. Patient may have tetany, muscle spasms, hyperreflexia, tonic-clonic convulsions, laryngeal spasms, and death from asphyxiation. The Schwaztek sign, there's the tapping of the cheek, which results in twitching of the upper lip, and the Trousseau sign, which is sustained inflation of a sphygmomanometer placed on the upper arm to the level above systolic blood pressure with resultant painful carpal spasms. And here it's showing these two different signs here and what you can see with this patient with hypoparathyroidism. Evaluation, look for a low calcium level and high phosphorus level. Treatment, you want to alleviate the hypocalcemia, parenteral administration of calcium, and oral vitamin D and calcium. Dysfunction of the endocrine pancreas, we have diabetes mellitus. This is a group of metabolic diseases characterized by hyperglycemia resulting from defects in insulin secretion, insulin action, or both of these. There's 4 categories. Type 1 is beta cell destruction, usually leading to an absolute insulin deficiency. Type 2, ranging from predominantly insulin resistance with relative insulin deficiency to predominantly an insulin secretory defect with insulin resistance. There's other specific types and also gestational diabetes. This is diagnosed based on glycosated hemoglobin, hemoglobin A1C, fasting plasma glucose levels, 2-hour plasma glucose level during glucose tolerance testing, or random glucose levels in an individual with symptoms. Here's just showing the differences between type 1 and type 2. Okay, so let's look at type 1 diabetes, the most common form of diabetes in those under 12 years of age. Diagnosis peaks at 12 years of age. And this results from loss of beta cells in the pancreatic islets. There's a genetic susceptibility, a first-degree relative with type 1 diabetes, and 50% concordance rate with twins. The strongest association was with histocompatibility complex, or MHC. Environmental factors, viral infections can lead to this, especially enteroviruses, exposure to other microorganisms such as H. pylori, or exposure to cows' milk proteins and lack of vitamin D. It's supposed to be milk right here. Spelling error. Immunologically mediated destruction of beta cells, lymphocyte and macrophage infiltration of the islet cells results in inflammation and islet beta cell death. Production of autoantibodies against islet cells, insulin, glutamic acid decarboxylase, or GAD, and other cytoplasmic proteins. Hyperglycemia, glucagon, and hyperketonemia. Before hyperglycemia occurs, 80 to 90% of the function of insulin-secreting beta cells and the islet of Langerhans must be lost. Beta cell abnormalities are present long before an acute clinical onset, and alpha cell and beta cell functions are abnormal. There's lack of insulin and amylin, and this is relative excess, and there's a relative excess of glucagon. More in type 1 diabetes, the clinical manifestations, there's that long preclinical period with gradual destruction of the beta cells. This affects metabolism of fat, protein, and carbohydrates. There's osmotic diuresis, which leads to polyuria and polydipsia. Patient may have weight loss and polyphagia. Evaluation is the presence of symptoms in fasting and postprandial states. C-peptide, which is indicative of residual beta cell mass and function. And many kids are first diagnosed with signs and symptoms of DKA. There can be a sweet or fruity odor to the breath when they're DKA. Treatment, this is designed to achieve optimal glucose control without causing significant hypoglycemia. Patients need insulin supplementation, meal planning, an exercise program, and self-monitoring of blood glucose levels. And here's the main symptoms listed here on this chart. Now moving on to type 2 diabetes, this is much more common than type 1. The highest prevalence is in African American women. And there's an increased prevalence in children, especially Native American and obese children. There's an environment and genetic interaction. Risk factors include age, obesity, hypertension, physical inactivity, and a family history. Metabolic syndrome, now this is a constellation of disorders. The patient has central obesity, dyslipidemia, prehypertension, and elevated fasting blood glucose level. And with this metabolic syndrome, there's a high risk for developing type 2 diabetes and associated cardiovascular complications. More in type 2 diabetes, the pathophysiology, there's genetic, epigenetic, and environmental influences, insulin resistance and decreased insulin secretion by the beta cells. Insulin resistance, there's suboptimal response of insulin-sensitive tissues in the liver, muscles, and adipose tissue to insulin. Glucagon acts as an antagonist to insulin. Amylin is decreased with diabetes, and amylin increases satiety and suppresses glucagon release from the alpha cells. Ghrelin, there's decreased levels associated with alterations in insulin secretion, insulin resistance, and obesity. Clinical manifestations, polyuria and polydipsia may be present. Other nonspecific symptoms the patient may complain of includes fatigue, pruritus or itching, recurrent infections, visual changes, and symptoms of neuropathy. Evaluation, the diagnostic criteria is the same for type 1. Prevention hinges on diet and exercise and having a healthy lifestyle. Treatment, pharmacological therapy, lifestyle modification. You want to establish appropriate glycemic control, restrict caloric intake, and encourage the patient to exercise. And here's more in the symptoms of type 2 diabetes. Now, diabetic ketoacidosis, this is a serious complication of diabetes mellitus, and this develops when there is an absolute or relative deficiency of insulin and an increase in levels of insulin counter-regulatory hormones. This is most common with type 1 diabetes, but can also occur with type 2. Most common precipitating factors include intercurrent illness, such as an infection, trauma, surgery, or myocardial infarction. There's interruption of insulin administration that may also result in DKA. Clinical manifestations, polyuria and dehydration result from osmotic diuresis. Deficits in sodium, phosphorus, and magnesium. Most common electrolyte disturbance is a marked deficiency of total body potassium. Vomiting, abdominal pain, dehydration. The patient may have acetone odor to the breath, too small respirations, CNS depression, thirst, and polyuria. Evaluation, symptoms of vomiting, abdominal pain, dehydration, and the acetone odor to the breath, and changes in the sensorium. Look for the serum glucose level greater than 250, a bicarb level less than 18, and a serum pH greater than 7.30. In the presence of an anion gap, in presence of urine and ketones. Treatment is administration of insulin, giving fluids, and addressing any electrolyte deficiencies or deficits. Hyperosmolar hyperglycemic non-ketotic syndrome, HHNKS. This is a life-threatening emergency. This is often precipitated by infections, medications, non-adherence to diabetes treatment, or a coexisting disease. This complication is more common with type 2 diabetes. Pathophysiology, this differs from DKA in the degree of insulin deficiency, which is more profound in DKA, and the degree of fluid deficiency, which is more marked with HANKS. This is characterized by lack of ketosis, and glucose levels are considerably higher than in DKA due to volume depletion. Clinical manifestations, glycosuria and polyuria. These result from extreme glucose elevation. As much as 19 grams of glucose per hour may be lost in diuresis. Neurological changes such as stupor may occur. Evaluation, looking for that high serum glucose concentration, often greater than 600. Near normal bicarbonate pH and serum osmolality greater than 320, and either absent or low levels of ketones. Treatment is insulin infusion and fluid repletion over 24 hours. Dehydration is more severe than with DKA, and fluid replacement with crystalloids or colloids is more rapid. Potassium deficits may be extreme and require several days of treatment. And here's just a chart with the key differences between these two disorders, NKS and DKA. Now, the effects of diabetes, there can be chronic complications of diabetes, such as diabetic retinopathy. These are microvascular complications, disease in the capillaries, and it's the leading cause of blindness, end-stage renal disease, and neuropathies. There's decreased tissue perfusion, and retinopathy is the leading cause of blindness. This develops more rapidly in type 2 diabetes rather than type 1. There's a risk for cataracts and glaucoma, and there's 3 stages leading to vision loss: non-proliferative, pre-proliferative, and proliferative. Laser treatment is used to reduce vision loss from diabetic macular edema and neovascularization. Now, some of the other complications that can occur with these microvascular changes, diabetic nephropathy. This is the most common cause of end-stage kidney disease. There's early phases are generally asymptomatic. There's multiple mechanisms that contribute to nephropathy. Microalbuminemia is usually the first manifestation. Microalbuminemia is independent risk factor for CVD and renal impairment. Later, hypoproteinemia, reduction in plasma oncotic pressure, fluid overload, anescara, and hypertension may occur. As renal function deteriorates, hypoglycemia may occur. Kidney loss loses the ability to metabolize insulin. GFR less than 10, patient may have uremic signs, nausea, lethargy, acidosis, anemia, and uncontrolled hypotension. Tight glucose control and ACE inhibitor use reduces proteinuria and slows progression of nephropathy. Diabetic neuropathy, this affects about 50% of those with diabetes, and this is due to chronic hyperglycemia. Distal portions of the neurons are initially and eventually more severely affected. Motor involvement results in weakness and muscle atrophy, especially in the lower legs and feet. Involvement of the ANS can occur early and affects GI nerves, bladder and sexual dysfunction, urine retention, and recurrent infection can occur. Cardiovascular autonomic neuropathy is a serious complication with heart rate variability, changes in baroreceptor reflexes, postural hypotension, dysrhythmias, painless MI, and sudden death. alterations in cognitive function, and there's an increased risk for dementia. Charcot neuroarthropathy or Charcot joint is a progressive degeneration and structural disorganization of a joint. And here's just listing different symptoms or issues that can occur due to peripheral neuropathy. All right, other complications of diabetes, coronary artery disease. There's macrovascular disease that involves the large and medium-sized arteries. There's increased morbidity and mortality. CAD, the most common cause of morbidity and mortality. And MI may cause death in up to 75% of those with diabetes mellitus. Hyperglycemia-induced endothelial dysfunction, impaired fibrinolysis, increased platelet aggregation, plaque instability, dysfunctional arterial remodeling, and fibrotic and calcified coronary arteries. And the guidelines are to reduce risk and improve prevention, screening, and treatment. Another complication is a stroke. This is twice as common in those with diabetes, and the ischemic stroke is more common in the hemorrhagic. Other factors involved are hypertension, hyperglycemia, hyperlipidemia, and thrombosis. Aggressive management of blood pressure, hyperglycemia, and lipidemia is important in treating patients with a stroke. Peripheral artery disease, there's an increased incidence of PAD, neuropathy, gangrene, and amputation in those with diabetes. Atherosclerotic process is more common at a younger age and advances more rapidly in those with diabetes. Age, duration of diabetes, glycemic control, genetic and additional risk factors influence the development of PAD. Atherosclerosis combined with peripheral neuropathy causes occlusions, ulcers, and gangrenous changes of lower extremities. Smaller vessels often have more occlusions than the larger vessels. All right, some other chronic complications of diabetes, infections. There's an increased risk due to impairment of vision, hypoxia, pathogens, blood supply, suppressed immune response, delayed wound healing. And the risk is further increased with those undergoing surgery and taking medications such as immunosuppressant medications. All right, moving on to alterations of adrenal cortex, disorders related to hyper or hypofunction of the adrenal cortex. Hyperfunction that causes increased levels of circulating cortisol leads to Cushing disease. Hyperfunction that causes increased secretion of adrenal androgens and estrogens leads to virilization or feminization. And hyperfunction that leads to increased levels of aldosterone leads to hyperaldosteronism. Hypofunction leads to Addison disease. And here's the difference between these two different clinical manifestations between Addison's and Cushing's. All right, so let's go a little more over Cushing's. This is a complex of clinical manifestations resulting from chronic exposure to excess cortisol. Cushing disease is the overproduction of pituitary ACTH by a pituitary adenoma. Ectopic secreting non-pituitary tumor, small cell cancer of the lung, can cause hypercortisolism. Excess ACTH stimulates excess production of cortisol, and there is a loss of feedback control of ACTH secretion. Clinical manifestations include weight gain, which is the most common feature, and this is due to an accumulation of adipose tissue. The patient may have truncal obesity, a moon face, and a buffalo hump at the back of the neck and the back. Glucose intolerance occurs, and there's protein wasting due to catabolic effects of cortisol on peripheral tissues. Evaluation, urine-free cortisol concentration higher than 50 per 24 hours, abnormal dexamethasone suppressibility, or either urinary or serum cortisol, and simultaneous measurement of ACTH and cortisol levels. Treatment, differentiate the cause, can be treated with medication, radiation, or surgery. This chart just shows the different symptoms there. Hyperaldosteronism, this is the excessive aldosterone secretion by the adrenal cortex. This can be primary or secondary. Primary, there's excessive secretion of aldosterone from an abnormality of the adrenal cortex, usually a single benign aldosterone-producing adrenal adenoma. There can be fluid and electrolyte imbalances, increased renal sodium and water resorption with corresponding hypervolemia and hypertension, renal excretion of potassium, and edema usually does not occur. Secondary, there's excessive aldosterone secretion from an extra adrenal stimulus, most often angiotensin II, through a renin-dependent mechanism. The effect of increased extracellular volume on renin secretion may vary. Clinical manifestations include hypertension, hypokalemia, renal potassium wasting, and neuromuscular manifestations. Hypertension is resistant to treatment. Evaluation, various clinical and lab measurements to look at there. Treatment, you're going to want to treat the underlying cause, manage the hypertension and the hypokalemia. And here's just some differences between the primary and secondary. All right, finally, adrenal cortical hypofunction or Addison disease. Cause is by inadequate stimulation of adrenal glands by the ACTH or a primary inability of the adrenals to produce and secrete the adrenal cortical hormones. Addison disease is primary adrenal insufficiency. Pathophysiology, there's inadequate corticosteroid and mineralocorticoid synthesis and elevated serum ACTH levels. Clinical manifestations, weakness and easy fatigability, hyperpigmentation and vitiligo, anorexia, nausea, vomiting, and diarrhea. Hypotension can lead to vascular collapse and shock. Evaluation is with serum and urine levels of cortisol are depressed with hypercortisolism, and ACTH levels are increased. Treatment, lifetime glucocorticoid and mineralocorticoid replacement therapy. Patient may need some diet modifications, and you want to correct any underlying disorder that's leading to this. If you have any questions, please email me and let me know. Again, I only covered certain portions of these chapters. Make sure that you're reviewing the chapters in their entirety in order to learn this information and to prepare for the exams. Thank you all and have a great day.